Good morning and welcome everyone to this session, which is going to be on looking beyond the boundaries of the NHS. And I should say a special welcome to people who are joining us on the live stream. As Jennifer said, I lead the Healthy Lives work at the Health Foundation, and our focus on that work is around really, first of all, trying to demonstrate the value of good health to society and the economy, because we really believe we've got to show that health is an important value and something that we invest in. And the other thing that we are trying to promote is much greater cross-sector action on the wider determinants of health. And by cross-sector, I'm talking about the private sector, the public sector, and the voluntary sector, because all of the things that we experience in our day-to-day lives affect our health. Now, one of the things we talk about in our Healthy Lives work is that, obviously access to high-quality healthcare is essential when you need it, but in reality, it's not the majority of what keeps us healthy. And if you follow the work we do at the Foundation, you may well be familiar with this infographic that we've been using to really try and explain the wider factors that keep us healthy as we grow up and as we age. And so, factors around social determinants such as our families, communities and friends, economic determinants such as money and resources, the environmental factors that shape our lives, whether it's access to green space, air pollution, so on, and also commercial factors, so things around the food system that we live within, or other aspects of the sort of commercial world. But thinking about this session this morning, I kind of thought, well, there's actually another question we could ask, which is, what is the context for the NHS? So, people working in the NHS, it's not in a bubble. It is operating in a context where all these factors are heavily shaping the way in which people experience healthcare. So if we took something like transport, how easy is it for people to access the services that they need? How easy is it for them to visit loved ones? People relying on public transport, actually this becomes extremely difficult in many parts of the country. What are people's housing situations? Do they live in a healing environment? I think one of the things I was most shocked by this year was seeing a report that showed a man who was rough sleeping with a stoma bag. And you kind of ask yourself, what kind of country is it where somebody can have that great medical care yet still is ending up sleeping on the streets? We know family and community is important to how we heal, as well as the environment that we're in. And probably fundamental to all of this is the money and resources that we have. Being ill is expensive. Being poor makes you ill, but being ill is expensive. And so obviously if you have limited money and resources, you're in a much more difficult place than other people. So this question of how the NHS operates in this context is going to be the theme for this morning's discussion. And we've got three speakers. Dom Allwood from the Health Foundation, who's going to start by doing some sort of framing of how we're thinking about these challenges at the Health Foundation. Kieran Boyle, Chief Executive at Guy's and St Thomas's Charity, who will be sharing some of the work that they do in Lambeth and Southwark that really starts to think about the wider context that the NHS there is operating in and how it can be shaped to get the best possible outcomes for people who live there. And Helen Crimlis, who's the Deputy Medical Director and Director of Undergraduate Psychiatry at Sheffield Health and Social Care NHS Foundation Trust. And she'll be reflecting on what some of these issues mean for the training of our future workforce. But what we're going to do, people have been sitting for a while now, we're going to start with a bit of interaction, and we're going to have in a moment some questions that we're going to ask you to think about on your tables. People online, obviously we hope you'll be thinking about that, and then we're going to be using Slido, which I know has been mentioned already, to have a few multiple choice questions and sort of explore our sort of shared understanding of some of these issues in the room. So if you haven't got access to Slido, now is a good opportunity to do that. And everyone will be able to vote. So whether you're in the room or whether you're joining us through the live stream, you will be able to participate in this. So, these are the questions that I'm going to suggest we spend a few moments thinking about. So, this has been talked about already, I know. The gap in life expectancy in England between people living in the 10% most affluent areas and the 10% most deprived areas is 7.5 years. So our question is, what is a gap in healthy life expectancy? And these are stats for women, just to say. So healthy life expectancy is the number of years somebody can expect to live in good health. So that's the first question we're going to ask you to think about. The second question, again, some of this got touched on, I know, in the earlier session. The prevalence of diabetes amongst the white population in England is 8.1%. What's the prevalence of diabetes amongst the Black and Asian population? Third question is, if the NHS budget, including capital spending, had followed the same trend as the public health grant, what would it be now? The fourth question is, on average, a GP is responsible for 2,160 patients. That's the average number across the country. To the nearest 10, how many patients can a GP working in the most deprived 10% of CCGs expect to be responsible for? And the last question is, the best coverage for adequate cervical screening of eligible women by the upper tier local authority. So this is something that's organised through local authorities, but it's an NHS responsibility. If the best coverage is 84%, what's the lowest screening rate? So they're the questions we're going to ask you to consider. Now, I just want to say, don't worry about the maths here. There are going to be like multiple choice answers, and my steer to you is just kind of have a conversation. Do we think it's higher, lower, about the same? So I'm going to ask you to just chat in the room for a few minutes to reflect on some of this. Don't try and necessarily answer them all. Pick something that you're curious about, maybe. But just so we can bring the room back together, when it's time to move into the voting, I will raise my arm, and if you see me, please raise your arm, and then we know that that will bring the room to silence. Okay, so please take 3 to 4 minutes to consider some of these questions. I know, just to say, some of you have already spotted, are on Slido, and there are the multiple choice answers there, but what I'm going to suggest we do now is move into the voting. I know some people have started, but you need to go to Slido, enter hashtag HF Event 19. The instructions are in the pack here. Select the session that we're in, and what you'll see for each of the questions is the multiple choice options. They're all in the same thing, so you just work through. So we'll just take a sort of minute and a half for people if you haven't already started to start inputting your answers. If you don't actually have Slido with you, do it with someone else. And again, this is something that the online audience will be able to join in on, so we'll get hopefully quite a significant set of data. Okay, we're going to look at the results now. Right, so what's going to happen is that we'll get the distribution of the voting. The right answer will be highlighted. It won't show it in the order that it was on the kind of multiple choice. It will show the one that got the most kind of votes, as it were, first, and then it will highlight the one that is the correct answer. So let's look at the first one. I think. Do I click again? Oh, it's there. Great. Okay, so and the correct answer was, everybody realised it was going to be a lot, but actually it's a lot higher than clearly quite a number of people in the room and online appreciate. And I just think this is a really important thing to reflect on, this difference in healthy life expectancy. In some parts of the country, women have a healthy life expectancy of 52 years. So this has real implications for how we think about the way we deliver health services. So let's look at sorry, you put the next one up? Great, thank you. Right. So prevalence of diabetes, yeah. Okay, no, that's good. So again, people realised it was going to be a lot higher. I think it's probably worth commenting this is an average, and so in some parts of the country, actually, obviously, it will be higher than 15.4%. And it's also worth reflecting, this is because, obviously, race and ethnicity is something that heavily shapes our socio and economic status because of the structural barriers that we have in our society. So, again, something we really need to be thinking about when we're looking at the provision of healthcare. So if we move on now to the, if the NHS budget had followed the same trends. So yes, yeah, you would have a lot less money if your budget in the NHS had been following the same trend as the public health grant. I think the other thing, and you know, this is so important because the public health grant is a budget that is dedicated to prevention activity. What I'd also say is that the cuts it's had are not dissimilar from the cuts that have been experienced in wider local government, with the exception of adult social care, where there have been cuts of around 30%. And when we think back to the infographic and all the things that we were showing on that, local government has a huge part to play in creating and shaping the environments that we live in, and therefore cuts to services like parks, libraries, housing and so on are all really critical. Moving on to GPs. Yeah, again, well, this I'll take this as lots of people have read the recent Health Foundation report on this, which is where it came from. So, you know, you kind of might think that in areas of higher need, there would be GPs would have fewer patients to have to manage. That kind of, you know, if you have a population that has more need and greater ill health, but in reality they are managing significantly more, so this again is a problem. And then finally, let's look at the screening one. So, okay, yeah, so the coverage is slightly better than most people thought it might have been. But again, another example of where something that the NHS is responsible for, kind of it's in their gift, but actually by not having better screening rates consistently across the country, it kind of essentially leads to a bit of an own goal later on. So, hopefully that's given us a bit of context for the next 45 minutes. What we're now going to do is I'm going to ask Dominic Allwood to come and just share some of the ways in which the Health Foundation is thinking about this question of how does the NHS need to think about its role in the wider system. So over to Dominic, thank you.
Good morning, everybody. Thank you, Joe. It's great to be able to talk about this for a few reasons. One is I'm leading a portfolio of work at the Health Foundation, thinking about the different roles that the NHS can play in improving population health. But it's also been a passion of mine for a long time. I'm a consultant in public health medicine. I'm not going to put many stats up like Joe is, don't worry, if I don't bore you with the statistics. But I work out in the NHS as well, in an acute trust, thinking about how our hospital's role needs to change and thinking about population health. So this is a subject that is very dear to my heart. I could ramble for a long time, but I'm going to stick to 10 minutes to make sure that we have enough time to think about the practicalities of this. I'm going to focus on providing a bit of a framework. It's going to have 4 lenses. Jennifer talked about the conference today having 2 lenses. I'm going to add 4 lenses into the first lens, which makes it a bit complex. And for those of you who like a framework, I hope that it does resonate with you. It's fairly simple, and it probably is things that you're already thinking about, but I hope that this just surfaces some of the simplicity in the way we can start thinking about what we need to do, because some of these challenges that Joe has showed around population health and inequalities are very complex, and it can be easy to say, well, where do we start and how do we have impact? So the framework will hopefully help you do that. For those of you who are the pragmatist learners, the practical people, the speakers that are going to come after me will be talking more about the practical examples, so don't worry, it won't all be theory. And for those of you who reflect and learn by sort of thinking, we'll have some time for question and answers afterwards, but we'll also be carrying on the conversations very much through the work that we're doing, so we hope that you'll follow up with us on this. So Joe mentioned the NHS actually in some ways has a very small role to play in the overall context of how people experience health, good health and poor health. You can see it nestled here at the side of this diagram. It accounts for around 10 to 20% of people's health through the access to high quality healthcare. But we think it's really important still that we understand how to maximise that potential. And I guess what we're exploring through this session as well is really some of the wider influences that the NHS can have on this rainbow of all the things that make people healthy or experience ill health. So actually through a lot of the NHS's work and activity, we can be influencing population health on a broader perspective and thinking about some of the boundaries in which we cross in order to tackle that. And really that's the focus of what we're going to talk about today. So the first piece of my model is about clinical care. And this is really in some ways a bit of a catch-all bucket because it is about where we deliver our care, the context in which we do that, the conversations that we have between healthcare professionals and patients, the interventions that we do deliver, the pathways we design. It's a bucket for a lot of things, but it is the core bread and butter of what the NHS does. And we think and we know that we can do better around prevention and delivering that through these contexts, but also thinking about how we respond to people's wider contexts. And so we've heard from Jo about the way in which people live their lives, for example, how they experience their housing or their social networks influences their health. So when you're seeing a patient in a respiratory clinic coming in with breathlessness, giving them medical interventions will only get you so far in order to alleviate their symptoms and improve their health. We need to think about the conditions in which they live. Now, I'm not advocating that you all need to become damp specialists in housing, but we do need to think more about people's contexts. And we need to bring that into how we design and deliver healthcare and the improvements that we make to healthcare. And what that really leads us to think about is how are we understanding the populations in which we work with and we serve, and how do we really understand their needs and inequalities. And whilst it's heartening when I've been to meetings recently, hospital boards, etc., they've started showing the heat maps of inequality in their local population, and they've moved beyond just showing pictures of their grand buildings about the services they deliver. What it's left me thinking is, well, how are they using that information and that data to drive the design and the delivery of their healthcare? So it's all very well knowing that you do have these disparities, but what are you doing around that? So it's really important that we think about our clinical care as being the core of our work, but actually how do we better focus on prevention in people's contexts? There's a few examples. There's people sitting in this room doing lots of great work around that. One is Pathway. Alex, I didn't mention that I was going to get you to stand up, but give everyone a wave. Come on. Everyone can see Alex over there. Alex is the CEO of Pathway, and this is about an intervention that happens in the healthcare setting for patients who are homeless, and it helps to try and coordinate care better and also think about patients and getting safe and effective discharge. And what we're thinking about really here is how do we get these interventions more embedded into healthcare and work with partners like Alex and others. So that's the clinical care. I promise I'll speed up. The second one is about the NHS being an employer, and again, this is a bit of a catch-all bucket as well. Thinking about being a role model employer, really being a promoter of health and well-being, which we know at the moment is not something we're doing as well as we can. Thinking about the environments in which we provide for our healthcare staff, but also in which we deliver healthcare, and thinking about the access and the role of the NHS providing good quality employment, knowing that that influences health as well. So there's a few things wrapped up in that, and we know from staff surveys and others that we aren't doing a good job around health and well-being of our staff. And that is not experienced equally across our staff groups. So that lens of inequality is really important here. Many of you will be working in organisations that are tackling health and well-being of staff, but how many of you are thinking about the differences that exist amongst your staff groups? There's a hospital trust just down the road here in North London who had a similar thought around this. Their staff health and wellbeing statistics were fairly good compared to the national levels, and they were winning awards for their employment health and wellbeing interventions. But when they looked more into the data, particularly around things like their uptake of physical activity interventions, they found that most of those were being utilised by bands 7 and above. So, for example, the Ride to Work scheme, they found a significant number of people buying bikes that were for triathlons or upgrading to a Brompton to commute to work on a train, rather than really tackling the root causes of what we're trying to do with active travel. So they worked with their bands 1 to 2 staff in facilities and estates who had some of the highest sickness and absence rates to co-produce and co-design interventions around staff health and well-being, including things like opening a bank account, learning to cook, taking staff away for the weekend to Wales to see the countryside, and many of these interventions showed a really significant impact on reducing staff sickness and absence. Now, what I'm not saying is we all need to be rolling these things out, but we do need to be thinking about the differences that exist amongst our staff groups in the same way as our population, and also understanding the evidence base better about what works around staff health and well-being. The third role that the NHS can play in improving health is through the NHS as an anchor institution. Jennifer mentioned it earlier, and it's a big area of work that we're taking forward in the Health Foundation. And this is about the NHS's role in influencing health and well-being of its local communities through some of the non-direct clinical care and activities that it undertakes, and being more intentional in the way that it does this around, for example, purchasing and procuring, so that it really maximises the social and economic impacts that it can have in a local area. Now, I don't want to be a spoiler for what's coming next, but there is a breakout session just directly after this that focuses on the NHS as an anchor. So if you do want to find out more, do go to that, and we're just launching an infographic on that today. And then the final role is that one just there at the bottom around the NHS as a system partner. And I use the term partner purposefully rather than leader here. In many places, the NHS is not partnering or participating in the way that it can do with local organisations and others. And so we're thinking about actually how do we get better at those partnerships, thinking about integrated care, and in England particularly the ICSs and STPs being places where we need to integrate better around population health. But more broadly, how do we work with other partners that don't sit inside health and care, for example, schools, policing, housing and others, to think about our places and how we improve health. So really about being a partner and a participant in the local place. So that concludes my model. I guess the one thing to say about that is all models are wrong, some are more useful than others, and I hope that that is a helpful and useful lens that will signpost a bit of what's coming in some of these sessions over the next part of the morning, particularly the anchor institutions and the NHS as a partner. We've got people talking about devolution and other things in the session, so do go to those because we will be talking more about them. But I hope that provides a segue into my next speakers, who are going to talk about some examples that sort of lie within this.
Thank you, Don. We'll go straight into Kieran.
I'm going to hand you the baton.
Super. Thank you. Good morning. Right, so I'm going to get going. I'm going to try and shoehorn in a metaphor here, a maritime one. So to go from anchor institutions, to maritime maps, and talk about mapping. And let's see how that one goes. I'm going to share some of the work that we're doing at Guy's and St Thomas's charity, and in particular what we're learning about working across boundaries, particularly when focusing on the social context of people's health, and particularly when focused in place. And to get going with that, I wondered, could everybody just take out their mobile phones, please? Thank you. Go on, everybody. Could you unlock it? Great. Could you hand your mobile phone to the person sitting next to you? Brill. So we're just going to leave it there. Okay. So this, I think, is what is involved in working across boundaries, or place-based collaboration. You're probably feeling a little bit excited, a little bit nervous. You might know the person that you've handed the phone to. You might be thinking you probably should have introduced yourself earlier to them. And that's kind of what's involved with all of this. We're at Guy's and St Thomas's charity, alongside providing support for Guy's and St Thomas's NHS Foundation Trust, we're an urban health foundation, a place-based foundation. So we focus on health issues that affect cities in particular. And in cities, certain things are going on. Firstly, you have great population density, you all know this, but you have many worlds often kind of right next door to each other, sometimes overlapping, sometimes even colliding. You have very rich cultural and ethnic diversity, and in a lot of cities you have high levels of income inequality, and those all play out into a sort of complexity of life in general, but particularly life as you think about people's social context and their broader health. And we focus on that complexity. It plays out in the sorts of health issues that we focus on. So we focus on two in particular, one being childhood obesity, the other being multiple long-term conditions. Interestingly, they're different types of health challenge. So childhood obesity we would look at and say that's broadly a coordination health challenge. Pretty much everybody knows what to do about childhood obesity, it's just difficult to do it all. Multiple long-term conditions, we would say, is a different sort of challenge. It's an exploration one. So in Lambeth and Southwark, where we do a lot of our work, of every 5 people who have diabetes, just one of them only has diabetes, which is to say that multimorbidity is a norm, but there's not very much evidence out there on what you can do to address this issue. But what's consistent about both of these two issues, childhood obesity and multiple long-term conditions, is that social context seems absolutely critical. There's very clearly an income gradient to these challenges. So childhood obesity, kids from poorer backgrounds are 3 times more likely to be obese than kids from wealthier backgrounds. Multimorbidity, people start their journeys into having multiple long-term conditions, if they're from lower income backgrounds, on average about 10 years earlier. So there's kind of a steep income gradient. Social context seems key, and as a result of that, if you're going to address them, then you need to be working with lots and lots of different actors, as Joe said, from across different sectors. And that's really what I'm going to talk about, some of our experience with many of the people in the room here, around what's it like to work across these sectors and what are we learning in the process. We try and deal with some of this complexity by taking a very place-focused approach. So when we say place, we think of place broadly as a canvas on which you can sketch out a systems approach. Our work, we think of an actual place, we think of a type of place, and we pay great attention to the context of place. So let me go through those in turn. So firstly, an actual place. For us, our work is in South London, specifically in the boroughs of Lambeth and Southwark. We've been there for 500 years, and in our mind, they're almost a mirror of the world's future population. Incredibly cosmopolitan, high levels of income inequality, but very vibrant places. But more than the actual place, we focus on a type of place. So thinking about our work on childhood obesity, where we kind of go to where childhood obesity is, we see the things that you would expect. So the kind of the white-grey bits are where levels of childhood obesity are very high. The blue bits are the lowest income areas across the 2 boroughs, and the yellow areas are the areas with the highest BAME representation. So we're working in those sorts of neighbourhoods, low income, ethnically diverse. But most of all, we're trying to focus on what is the context of these neighbourhoods. So actually, we look at these neighbourhoods very closely and try and understand, well, where are the schools, where are the supermarkets, where are the takeaways and restaurants, and how are they playing out in people's lives? And we think that context is absolutely critical, because it gives us a sense of where to be active and how to be active in working with people to try and improve some of these health issues. So that's kind of the first set of maps we think about. We then think about a second set of maps, which is actually mapping out the issues themselves. So we think of this in 3 different ways. So firstly, kind of deep systems mapping of the issues. So what is the system of the factors that sit behind something like childhood obesity? What is the available evidence out there on what works? Perhaps most critical of all of this is what is the lived experience of local residents of these sorts of issues? And this sort of work can take you to some quite interesting places that you might not otherwise end up at. So taking childhood obesity, for example, deep systems mapping will talk about the importance of the street environment, and in particular how kind of streets are just saturated with opportunities to eat cheap and unhealthy food. The evidence will tell us that actually a lot of how we choose what we eat is totally unconscious. It's just what's around us. So that would suggest that probably you need to be looking at the foodscape, what's available to people to eat. Lived experience would tell us that often it's not where you first think about looking. So I guess everybody would think childhood obesity, you need to tackle chicken shops. That's where everybody goes. But actually lived experience is telling us chicken shops might be part of the issue, but actually much more present seems to be convenience stores, local convenience stores, where you can buy really cheap food that's really bad for you, which particularly if you're on a lower income and you're thinking about accessibility and affordability, that might be the choice that you're making. But lived experience also tells us when we speak to residents of our neighbourhoods that the best way of engaging with those convenience stores might not be going through a retailing association. It might be speaking to the owners of those stores who are residents of that community and care deeply about levels of childhood obesity in the neighbourhood and just want to know what they can do about it. So often these three things together can take you to some quite specific insights that are then very helpful to engage with. And what we do is we use all three of these to help us define clearer programme goals that we and others can partner around. So, for example, in childhood obesity, we're trying to close the deprivation gap between levels of childhood obesity in the poorest areas and the richest areas in our borough, working in homes, schools and streets with people who can influence those environments. On our work on multiple long-term conditions, we're seeing how do you slow down people's progression into multi-morbidity, particularly for those at greatest risk, thinking about, well, what can you do around health and care to make it more personalised around the individual, but also what can you do in terms of people's social context, so their housing, their employment, their financial resilience, and what can you do in terms of people's community context as well, in terms of increasing their community agency. So, that all sounds pretty conceptual, I guess. So let me give some practical examples of what that means in practice. And I'll start that with saying what our third set of maps is, which is think about the scale of activity where you might be able to see that impact from. Because places where we're active is where we're trying to observe and understand effect. It doesn't mean absolutely everything is happening in that place. So a lot of levers are local and exist in local co-production, but some have to be national or international. So we think of activity at five different scales. So the first of those is the neighbourhood scale. So a lot of our work is really hyper-local, which is trying to convene partners often in a 500-metre radius or a kilometre radius, each of whom have some part of the puzzle or some route to it. So on childhood obesity, it might be layering up different organisations who can deal with healthy school meals, active travel, community nursing, affordable fruit and veg. Sometimes it involves investing in anchor organisations, to pick up on Dom's point. So those anchor organisations might be, for example, we've invested in a local community centre. Pembroke House is very old. And what we're doing with them is that we've built a space where local residents, local VCS, local GPs can convene in an area that has a disproportionate high rates of people living with multiple long-term conditions, a space for people to be active around this. The level above the neighbourhood for us is borough level, often is often very resonant for the NHS, this sort of level, and the sort of work we're doing here is trying to support the local NHS in developing a social prescribing network across the boroughs. Also doing work with every single major supermarket chain around running a series of trials around how do you nudge people towards healthier food. What's interesting for us about that is that pilot wouldn't work at a smaller level, you wouldn't have enough supermarkets involved. It's actually quite difficult to do at a city or national level because of the kind of some of the competitive dynamics involved in it. Next up for us after boroughs is thinking about what can be achieved at the city level. So we're based in London, and we think that actually a lot of what can be achieved at the city level actually exists in the space of political influencing. So, for example, learning from the example of Amsterdam, we've supported the Mayor of London to set up a childhood obesity task force, thinking about what does London have within its gift to tackle the fact that it has higher levels of childhood obesity than any other global peer city. And then after that, some of our work even goes national or international. So nationally, for example, we're doing work with the Health Foundation and others of engaging with national newspapers around the framing of childhood obesity. So pick up any paper, and typically childhood obesity is framed as about people lacking willpower and about poor parenting, never about the environments in which people find themselves, but that's what the evidence suggests is sitting behind the issue. And then even internationally, trying to achieve an effect in Lambeth and Southwark, we're doing some work with an organisation called Share Action, who are engaging with big investors, pension funds and the like, who themselves are engaging with big food-producing companies, talking to them about the reputational or regulatory risks of high sugar content food. So all of these are routes to impact locally. So why do I go through all of that? Well, basically to talk about what are we starting to learn about the sorts of partnerships that are involved across those different sectors. So, what are we learning about working across boundaries? Well, the first thing is about the importance of combining and connecting in place. we really are learning that you need to go to where people are if you're going to address these sorts of issues. We're also learning that when we're doing this kind of connecting in place, that 3 different types of impacts seem to occur. So the first of those is the direct impact of any individual actor. The second is some sort of kind of complementary impact. So for example, I spoke about some of the work we're doing around childhood obesity in neighbourhoods. We've supported a charity that's providing food vouchers to help lower income families be able to access fruit and veg. We've also supported another charity that's creating community freezers for people to be able to do community cooking and then have somewhere to store the food, because they might not have those freezing facilities at home. Those 2 things have quite a complementary impact to one another. But the third thing, probably most importantly, is that there's a collective impact, particularly collective learning amongst all of those parties around learning what's working in that particular place. The second thing we're learning about is just, and you will all know it, but the importance of surfacing different voices. And neighbourhoods aren't backwaters, they're areas with rich solutions. We're as likely to find the solutions to those challenges in those neighbourhoods as from any professional. But also they can direct you to where the real issues might be. So take multiple long-term conditions, for example. When we look at that at a national level, everybody talks about multiple long-term conditions, about ageing and about frailty, and that is a key part of it. But in our local neighbourhoods, 1 in 3 people who have 3 or more long-term conditions is under the age of 65. i.e. it's a working age problem. And that's kind of surfacing from the communities themselves and giving us a sense of where might we need to be directing efforts. Thirdly, working across sectors, it does seem to be as much about values as much as strategies, as much as about teams rather than organisations and individuals rather than the positions that they hold. And that's a different sort of mindset to hold. And finally, it is critical, as everybody will know, to think about investing in capacity, particularly if you're a larger organisation like the NHS, like a funder. Not only kind of capacity of smaller organisations or communities or resident groups, but also in your own capacity to learn. And so perhaps that's where I'll finish, kind of that sense of probably we all need to be a learning system amongst this. If I've done it right, though, I guess I tried to outline 3 different sorts of maps there. So the first map is mapping place, to understand where need really exists and where the energy is. The second map is to map whatever issue you're focused on, to understand the dynamics, the goal, and who your potential partners are. Third is probably the most important map, which is to understand your own role within that partnership. So are you a participant? Are you a convener? Do you need to get involved, or do you need to get out of the way? I think it's in those 3 areas that we're learning, getting the richest insights of what it takes to work across boundaries. I think there's a rich community of interest in this, which we're really delighted to be partnering with the Health Foundation on, and look forward to hopefully partnering with many of you on as well. Thank you.
Okay, so thank you. Some great framing up there from Dom, and some thoughts about how some of this can really be played out in a local place. In a moment, I'm going to take questions from the room. I'll take them in batches of 3. I'm really going to insist they are questions. The speakers are going to be around all day, I think, and able to get into discussion if that's what you want. But in the interest of time, really want to make sure we have some good, short, pithy questions. But before I turn to the room, so please do start thinking about that, but I'm going to ask Helen to really reflect on some of the things we've just heard and her own experiences about what some of these issues of working beyond the traditional boundaries of healthcare mean for the NHS workforce and the consideration we need to give to that.
Thanks, Jane. Fantastic speakers, thank you very much. I think, as Simon said this morning, workforce is our biggest challenge, but of course it's also our biggest opportunity, and something that we really have an opportunity to change now. We're going to be having 1,500 more doctors, 5,000 more nurses, a couple of thousand physician associates, development of our current workforce through advanced practice and a range of other opportunities. And of course there are also new roles into health and social care for those who fear or who shun or haven't had the opportunity to go into traditional roles: associates, apprenticeships, outreach, peer workers. This is a massive investment and provides us with an enormous opportunity, but makes enormous demands on the people with responsibility providing placements, for supervising, for training. The current model is strained beyond belief, and we have to think differently about how to train the staff of our future. I was called last week by, I work in Sheffield, and I was called last week by colleagues in Leeds who said, please, can you find some placements for 4 of our physician associates, because we can't find them in Leeds. How can that be? How can that be that a large city cannot find a few placements? Why do we not need to, why we must be thinking differently? So what skills do our trainees and students need to navigate the system that we're developing for the 21st century? I suggest that they need to be comfortable working in the ways that you've articulated today, across boundaries with both professional and non-professional experts in both statutory and non-statutory sectors. Developing educational opportunities in these third sector placements will both help with this and expand the number of placements that we have available for students. I work with Sheffield Medical School. We provide social accountability placements where all students go out into the communities. They see and experience the intersectionality between illness and the wider determinants of health, as well as seeing some of the innovation which is inherent in the frugal and fragile systems of the third sector. But maybe we need to do more to do that. I want to explore the opportunities that come from unlocking the potential in our neighbourhoods, in our communities, and recognise in particular the value that you've articulated, Kieran, around lived experience, personalised and co-produced care, not only in the delivery of our services, where we're quite used to doing that now, we've got some experience in doing that, but also in lived experiences in learning and teaching. We know that the presence of patients, service users and carers working alongside clinicians has a positive impact on culture. It enables us to access patient experience more easily. It provides peer support to patients. It provides a methodology for stimulating quality improvement using techniques like experience-based co-design or expert by experience projects. Maren Batalden's work reminds us that clinical interactions are always co-produced. It is through the process between people by which we come up with collaborative plans that work for our patients and users. We have the power to amplify this. If we co-create interventions and opportunities through health systems, we can deliver personalised care, empower patients, improve outcomes, and improve efficiencies. The placement costs for a medical student on placement is nearly £800 per student per week. Think what that might do, or what could be done with that in a system outside a statutory health system. So what about education and training? How can we achieve the same benefits by co-producing learning opportunities with patients, users and carers? There are lots of places now that do employ lived experience workers, but usually within our hospitals and institutions, and are increasingly used in education and training. In Sheffield, where I work, we employ lived experience workers, and they're really expert at developing the skills of empathy, engagement, challenging stigma, providing compassionate care, and therapeutic optimism. But this is really patchy in mental health, where I work, and even more so in physical health care. We've got very little evidence about how to do this, how to train and support lived experience workers. How far can we go along this journey? What can they get involved in curriculum design, in assessment, in the support of struggling students, in training? Who should be paid? On what pay scales? And how? How much power are professional educators going to cede? How do we capitalise on the successes we've got through recovery colleges, where health education is co-designed and co-delivered by educationalists and professionals and experts by experience in a more egalitarian way? Can we recognise and utilise the lived experience in our own staff? Most of us go into careers in health and care because of motivations which derive from our own lived experience, and we could see this as an asset rather than it being hidden or devalued. These are massive cultural shifts. I wish I'd been I was a medical student at Guy's, and I wish I'd had some experience through the project that you talked about. It would have been enormously motivating to me. It sounds fabulous. It's a great initiative from a large charity in a large city in the south of England. How do we enable this to happen in small towns, in rural communities across the country, where social capital is less prominent and where philanthropy is considerably more limited? We need to change our paedagogic practice, our regulatory frameworks, and our funding streams. We need to challenge the risk appetite of our institutions to think differently. We need to partner, as you've said. We need to hand over our mobile phones, as you've said. We need to share experiences and share risk with this and foster the trust necessary to make these changes. I hope, therefore, that the workforce challenges will stimulate a parallel shift in educational practice to ensure that the workforce that we do develop are fit for purpose in the 21st century, not just to survive, but to thrive, enabling our communities to do the same.
Thank you very much. Thank you, Helen. So I think that gives us a kind of another dimension to consider as we're looking at this. So I'm going to look across the room. Please, could I have a show of hands, people who have questions? I would like to take 3. We have one over there. We have one here. Hugh, one of the colleagues. Do we have any questions on this side of the room? Other questions? And Christine here.
My name is Shanti Vijayaraghavan, and I'm a consultant diabetologist in East London. And the question that I had was really about how a model like this is sustained and commissioned within current NHS commissioning systems. So many of us in East London have been trying to do something very similar to what you've been talking about. But the current young adult diabetes pathway that I lead does not have any flexibility for my dietitian to go and sit down in the local food academy and provide carbs and calories training, doesn't allow my peer support group to go bowling in the evening, doesn't allow our group clinics that we're providing now as part of an NIHR-funded project to happen in a leisure center, because our commissioning systems are still very silo-based, and I just wondered how that was addressed.
Great, so we'll pick that up. And here, Hugh.
Hi, I'm Hugh. I'm from the Health Foundation. I thought it was a great presentation, Kieran. I'm a Lambeth resident, so it's great to have you looking after us. So you talked about place-based approaches to improving health, and there's clearly much that can be done through collaboration, better investment in places. But we also know from Joe's talk there's bigger social factors that really influenced by more national, macro-level political decisions. Do you worry that a focus on place-based approaches can take the heat off national policymakers about what they should be doing around housing, income, and so on?
Okay. And here, Christine, at the front in the blue. Okay.
Thank you. Great presentations. I'm very struck by the issue of how important work is for people's health. In many parts of the country, the NHS can be the biggest employer in town, I guess not in Sheffield or London, but also the two charities are very big employers. And I wondered what approaches all 3 organisations have to reaching out to create work, to make work easy for some of the people that you've quite rightly talked about as being in most need.
Okay, great. So what I'm going to suggest, if we work through the panel, not expecting everybody to be able to answer every question, so if you can pick up on things that feel most relevant from your perspective. I think we had a question, maybe Kieran, you can talk about on the national macro level and how that fits in. I think some of the things around sort of the anchors and experiences, perhaps we and you may want to touch on that, all 3, on your experience of organisations of reaching out to work with people in the communities where we operate. And I think this commissioning point, it would be interesting, Kieran and Helen, to hear your perspectives on where you're seeing commissioning really trying to bring in much more of this co-design lived experience and so on.
All great questions. Let me start with the national local one, and it's a really good question. I guess our frame on this is what is the right information to inform national policy, and we really think it's about getting under the skin of issues. And one way of doing that is by being deeply attentive to place. So give like a very practical example of that. In our work on multiple long-term conditions, when we speak to people about multimorbidity, local residents, none of them speak about multimorbidity. None of them speak about multiple long-term conditions. In fact, people rarely speak about their conditions. They speak about moments of complexity and they speak about moments of loss. And the sorts of moments of loss that we hear about are people saying, I gave up work because I had 52 hospital appointments in a year, and I was embarrassed to talk to my colleagues of why I was taking so much time off work. It was easier for me to give up work. I think that gives a real insight to what national policymakers should be thinking about on this issue. Actually, back to Christine's point about the importance of work and the social importance of work to us. So actually we see them as not taking the heat off, but giving a more laser-focused guidance to what national policy should be focusing on.
Okay. Anything on commissioning?
Yeah, so it's a really... Helen, what would you...
So I really feel for you, Shanti, over there. It can be very difficult to working within the tight regulatory frameworks that we have around commissioning. I do think it's changing. I do think there are opportunities. I think the primary care networks that Simon talked about, and we don't exactly know where the new funding is going to come, but I suspect it's going to come into the area between primary and secondary care and intersectionality with third sector. So I think that those are the places where you might be able to find the freedom and the opportunity to do some of these things. I say within an educational framework, money is coming into organisations for training, but it's not very visible all the time. And I mean, I'm challenging people all the time to say, what are we doing with this money? And could we spend it better elsewhere, or some of it better elsewhere? The partnership working, I think, it depends on relationships, doesn't it? And if you've got your partnership organisations on board, then I think there can be small amounts of seed funding that can really make transformational change. And if you can get the data behind that, your bowling idea is just such a marvellous one, taking them all bowling in the evening, great. Those are the sorts of things that I'd encourage, but it's tricky.
Okay.
I guess one additional thought on that is that we've seen is people being very deliberate about trying to get access to other people's budgets than their own, that sort of deliberate blurring of boundaries. Give an example just from Southwark, just because you know it well, it's quite interesting there how the public health team have joined themselves up with the planning department, because I think that they found that they have access to different tools that both need. It doesn't answer your question for East London, but it's something about that deliberate blurring.
Okay. So Dom, reflections on any of that, and particularly the sort of anchor role?
Great, yes. Okay, I'll come to the anchors in just a moment, but I absolutely feel that that frustration and challenge of when you're trying to deliver interventions that might be outside of the traditional setting of healthcare, or working with partners who aren't traditionally within healthcare, so for example voluntary and charity, and others who are doing interventions that affect people's wider context and trying to deliver those through healthcare. So the outcomes are often found beyond the walls of the organisations in which they're being funded or delivered, and also beyond the time frames of that usual funding. And the things that you're talking about, Shanti, are very much out into the community. So how would you convince a funder through the hospital route to do that? I think it's a classic example of what Hugh and I talk about, of the wrong pocket, taking that really narrow view of the commissioning where the benefits are had and the interventions are happening. Some of the work that we're going to explore at the Health Foundation is looking at how we help organisations and teams doing that work make that business case. So what are the things that are the outcomes you can measure in the places that need to be measured, and what are the things you need to take a further long-term view on? So I'm really keen to have a conversation about that. And then finally, this notion of the anchor institution, absolutely, the opportunities to have good work, and the people that don't always have those opportunities to be able to have them. So how do we think about the volunteering, the apprenticeship schemes, and how do we convert that into meaningful work and understand what interventions work to do that? And once people are in our system working with and for us, how do we give them access to that good quality employment, and also help them to think about their own health and what that means to then keep and treat our patients in a way that promotes health, because we know that's a whole pipeline of stuff. So Christine, absolutely, you're doing great work in that area, but it's a complex area and there's lots of different elements to that. So classically, I'm a Simon here. I probably haven't answered the question, but
okay.
I've reflected there, Jo.
Okay, so I am conscious we are now eating into the break. So we don't want to do that. I would have liked to have had another round of questions, but I think we're running out. So I'm just going to finish by asking the panel sort of very quick answer to one question, which is, so let's imagine it's 10 years from now, it's the end of the NHS long-term plan, sets out quite an ambitious agenda around prevention and inequalities. So if you were to step into an NHS setting 10 years from now, what would you like to see that you perhaps don't see routinely at present?
I would like to see happy staff. I would like to see staff who are happy about going to work and who have the feeling that work isn't making them ill, which I think sometimes it is at the moment. And I'd like them to be as comfortable with the idea of keeping people well and preventing them being well as actually treating them. I need them to have that language.
Great. Tom.
I think a greater focus around value and valuing people, the value of the work that we do, but also the value of what that's doing to improve health. I know there's many people in here that are doing amazing work around thinking about improvement of healthcare, but how do we value work that goes on to improve health, and how do we do that through the lens of healthcare? So actually, if we were having this conversation in 10 years' time, it would be very much driven through the lens of improving health and promoting the value of what we do and thinking about stopping doing things that don't add value around improving health.
2009 doesn't feel very long ago, does it? So let's be realistic. I'd love to walk into a commissioning group and see them have available to hand a much clearer playbook around what can you do around the social determinants, which I think is actually a challenge for funders, for academics, for policymakers here. My fear is that we're still all pretty much narrating this issue rather than talking about practically how do you get into it. So I'd love us to have somehow built that playbook.
Okay, so there we have a challenge for all of us. We're going to go to the break. You'll go straight into your breakout sessions after that, which start at 11:15. So finally, just to say, first of all, thank you for all of you who've been joining us online. I hope it's been a good session to participate in that way. Thank you to everyone in the room for listening and participating. And, of course, thanks to the panel. So thank you.